colleagues around the world. I would like to welcome you all to a new episode of the EGVRS Retina world around the world. And today, our landing spot is kind of very cold sometimes in Michigan, United States. And today we're meeting with Professor Tariq Hassan. He's a professor of ophthalmology at Oakland University, Beaumont, William Beaumont School of Medicine. He's also senior partner as well as head of the Vitreoretinal Fellowship Training Program at the Associated Retinal Consultants. Professor Hassan has been the past president of the American Society of Retina Specialists, and currently he is the president of the Retina World Congress. Among the so many prestigious awards Professor Hassan has received, he received the American Academy of Ophthalmology Achievement and Senior Achievement Award, as well as the American Society of Retina Specialists Senior Owner Awards. He has published more than 160 peer-reviewed articles in several magazines. He's also authored and co-authored about 8 or more textbooks in the field of ophthalmology and retina. And he has been on the editorial board of most of the prestigious journals in the field of retina and ophthalmology so far. So without further delay, I give you Tariq. Hello, Tariq.
Thank you.
Welcome to the EGVRS.
Hi, Mohammed. Thank you. Nice to see you. It's been a long time since you've been here in Michigan with us, I think.
Yeah, more than 20 years. This is another thing. I have been with Tariq in these early days, and my early days as well. I was a research fellow with the ARC in the year 2000, and I had the pleasure of meeting Tariq there. I would say you didn't change. You never age.
I was going to say the same thing about you, but maybe it's something that happens to our retina as we get older, that we only remember what we used to see. But yeah. I wouldn't say the same thing to you. I don't know.
Yeah, I think so. Tariq, you were born in Texas, in Houston, yes. Texas. And then you studied your undergraduate medical studies, and later on the residency and fellowship, all in Michigan. So
that's right.
What a great change of weather. What a great change of climate you have had there.
Yeah, well, it was really all from my parents. You know, my parents are both from Cairo, and they came to the United States right before I was born to do some studies at Baylor University in Houston. And so I was born while they were there, and then I was a child there. But really later in my childhood, my parents moved to Michigan to continue their studies and their training. And then I was born in Michigan. And despite the weather, I love this place. I love the state. And so I've been here pretty much most of my career.
Yeah, it shows, because both residency, fellowship, and practice is only in Michigan. And since you mentioned your parents, I mean, both of them are doctors. Did they influence your choice of becoming a doctor as well?
You know, they were actually very good about not pressuring or saying anything about becoming a doctor, but they, both of them being doctors, and my uncle is a doctor, and the only other person from Egypt from my family who had come to the United States when I was younger. It's really all I ever saw around me, and it became just sort of the family business. I just went into it. Although they're not ophthalmologists, they do both now allergy and immunology. But just being a doctor, I think it was meant to be, sort of.
Okay, and what about ophthalmology and retina in specific? Why did you choose those two? I mean, the subspecialty and then the ophthalmology in general.
Yeah, so for me, it was actually kind of in that order. When I was very young, I think I was 11 or 12, I was playing sports, baseball, which is not so common in Egypt, but the ball, I was hit in the eye with a ball, actually. And I was only 11, and this was, many years ago. So I was taken to a retina specialist, and I would go every day initially, and then I must have had a hyphema. I don't really remember, but I would go every day for a few times, and then I would go every week for 4, 5, 6 weeks in a row while they looked at my retina. And I had a small little tear, which back then seemed to have been a much bigger deal to treat than it would be today. So they never really treated it. And, fortunately, I just pigmented it and have a nice chorioretinal scar around this tear when I was a child. But it made me aware of the concept of the retina and the eye, although my parents were not eye doctors. And then I went to medical school, and I thought I was actually going to be a thoracic surgeon, because I wanted to save lives and be the hero, And
Yeah.
then I realized that their lives were very bad. And I love families, and my family was very close, Egyptian family. I didn't want to be away from my family my whole life. So then I tried to find another field where I would be surgical and kind of the hero. And so really retina was the obvious choice. I don't think I would have been an ophthalmologist if it wasn't specifically for doing retina, to do these difficult things that we do.
Yeah, so you like challenging specialties in general. So cardiothoracic, retina,
Yeah.
endocrinology. Yeah, the spirit of challenge. Yeah, this is
Yeah,
what
I think
drives
that
me.
I really think that was it. I think that I realized that being a cardiothoracic surgeon would have been, disruptive to having children and enjoying spending time with them and having a nice life growing older, because I would look at those folks even in middle age or older age, and they still worked so hard that they had no family life, and I didn't want that either. So that's why I sort of found that area within another
Makes
field that was easier. Yeah.
Yeah, yeah. Actually, I know you're also not only interested in surgery, but you have a lot of interest in research. And I
Hmm.
know that during your medical school and during your fellowship, your main interest was research, and you kind of balanced this now with the hybrid practice, being in the research field and in the surgical practice field. So how do you find this balance?
I think that I've always been interested in answering questions, and I know that sounds easy to say, but really the research areas that have most interested me are ones that would have a very practical outcome or significance to patients that are sitting in our chairs. So for me, balancing a very busy clinical practice and surgical practice with research is actually perfect, because it provides me with most of the research material. Certainly when I was younger, I did more basic science research and a lot of things in the lab and with, operating on animals and things like that. But as my career has gone on and taking care of patients, of course, that has been now left for others who do that more full time. And I think the specialties are becoming such that really there are those that do a lot of research and those that do a lot of clinical. And you can do clinical research, but to do basic research and a lot of clinical work has become more difficult now because of specialization and such. So for me, I balance my research, because when I'm in the office every day or in the surgery, I want to be able to answer a patient's questions when they say, well, why, what are my chances of something happening? And if I don't know the answer to that, or I can't find the answer, that's something I'm interested in. Or if I think of why did we do such a thing a certain way? And if I don't really know the answer, then I look to see if there's a better way or something else. So I'm always trying to answer the questions that are posed to me in a daily situation, either in the clinic or in surgery. And so it
Yeah.
makes for a perfect marriage. Yeah.
Course, yeah. And also, I would like to ask you about your, personal retina idols that you've been looking up to during the early years of your practice, and how did they affect the way you think and the way you practice retina in general?
I've had several idols, and I think that one of the reasons why I stayed in Michigan for all my training is because I've been very fortunate to have been with some of the greats in retina within my own local area, and some of them, having been with us for a while. I actually credit someone who's not with us, who was at the University of Michigan where I did my residency, Mark Johnson, who was just past president of the Retina Society, who was a new junior faculty at the University of Michigan when I started my residency. And he really taught me how to think very objectively, because I think in general, physicians and surgeons, we don't think necessarily logically. We assume that we do, but we're very based on our experiences and our emotions and our you know our will to do things, but we don't think critically all the time because we are so based in our experiences. But so when I was a resident with Mark Johnson, he's very pragmatic and he thinks about everything he does, and I think that taught me how to do it in the context of retina, and he exposed me to all of these things. And that really is what made me apply for Retina Fellowship, is really following in his footsteps. And he remains a very good friend of mine now. And then I was fortunate to do my fellowship with George Williams and Gary Abrams and Mike Tracy and Mort Cox, who's now since deceased. But some of the real greats in retina taught me really how to do surgical retina, medical retina, and research at the very highest level. So when I watch these guys and see that they can do all that and have a happy life and become prominent in societies or in the research, and they sort of tried to do it all within the context of a happy life, they became my mentors, my idols. I always said I want to be like that. And I think that that's what I've tried to show for other people who've been able to watch me in my life, that you can have a happy life and try to do your best at everything that you choose to do.
Yeah. What about your kids? I mean, you said that I mean, from what you said now, it seems that you're a family guy. So you spend a lot of time with your family because of this balance that you just mentioned.
Yeah.
So of your kids had the chance of getting to medical school or are interested to go into medical school?
Yeah,
No?
well, interesting. So I have 4 children, and of the 4, only one, my youngest one, is likely to go to medical school. He's still in undergraduate college, but he's pre-medical, and he's likely to be in medicine. My others, though, my oldest was a biomedical engineer, and he's very interested in science and medicine, but he's more interested in the business side of things. So he's actually doing well. He has a startup company in surgical robotics in California. I have another daughter who is a business person, so she's in sort of the financial tech world of the blockchain and all of these things that I don't understand, and she tries to explain to me, and I just like, that's so much like a different language to me. But she's very impressive as well, and she's and then my next daughter is actually an actress. She's a musical theater performer who is a Broadway actress. So she performs in musicals, and currently is starring in a musical that's touring the country. She's in Washington, D.C. now at the Kennedy Center performing. So that's a completely different area than where I am.
You know, you just remind me that George Williams, he has also had one of his daughters into the art thing. So yes. I guess retina and art performance is something that goes together sometimes. Huh?
It may be, and interesting in our own same group that we have two daughters who have chosen that pathway. And actually, George's daughter has, become friends with my daughters, looked up to her, as being younger, and gave her some guidance earlier in her career, but she's still young. So so they're all doing things here and there and everywhere. So we spend a lot of time on the phone together, and a lot of video chat, and then certainly we get together frequently. They're great. They like to be around, so it's wonderful.
With this, we end this first part of this episode with Professor Tariq Hassan, and then we'll have a very short break and come back to you with the scientific part of this episode. Stay with us. Thank you. So welcome back, and this is the scientific part of this episode. We have Professor Tariq Hassan, and he will be sharing with us one of his very interesting presentations tonight. And Professor Tariq, please share your screen and give us your presentation, please.
Perfect. Well, thank you. I really appreciate the EGVRS and Mohammed, and I want to thank you all for inviting me. I'm honored to spend this time with you, and wanted to give you a little scientific talk about something that I find very interesting and very different than some of the talks that you may hear on the podiums around the world. I think it's a consideration that we don't normally make. And as I often like to do, I like to think about things that we may not realize are a problem, find out that they are problems, and then try to find a solution for it. So I want to talk a little bit about operating room sterility. So there is a big myth about surgery, and that myth is that we have clean and sterile operating theaters. But really, in reality, the air in most operating rooms everywhere and other patient care areas like our clinics and offices is not as clean as we think. And ventilation systems in most of these areas are not optimized to minimize potentially dangerous airborne particles. There are current technologies that actually can improve the air cleanliness and in these operative environments, and there are new devices that can make the air in any space cleaner than our current operating room air, potentially even in office settings. So when we think about surgical infections, particularly those in retina, we often think of endophthalmitis. And those are primarily things that we see from local flora. And I think everybody sort of appreciates and understands that endophthalmitis probably comes from the local flora in most situations. However, there are multiple other potential infection sources, whether the patient's instruments, equipment, the surgeon's hands, the surgeon's clothes, and the operating room traffic. But the main cause from all of that is the operating room air. And multiple studies on surgical site infections have shown that airborne particles, particularly droplets, skin scales, dust, debris, and all of these things from the ventilation systems are a main cause of infection. What you want to understand about operating room airflow is that there are two main types. There is a conventional mixed ventilation system where the inflow of air comes in from the ceiling and the outflow of air into the room is from the side, up and down. And what you end up with is a circulation of air in the middle of the room that causes turbulence. And this is theoretically supposed to dilute the infectious particles in the air, and then they're removed through the outflow systems. The other system is the downward laminar flow system, where the inflow of air through filters comes in from the ceiling, and the outflow is from the floor. So that the idea is that you have unidirectional parallel lines of air that take particles in one direction away from the patient. So what has become the standard of care currently is mixed ventilation, is laminar airflow and not mixed ventilation. And the use of high efficiency particle HEPA filters are paramount in getting the most sterile environment. So laminar flow can occur in an up to down fashion or in a horizontal fashion, but it's all about the parallel lines of airflow that direct bacteria containing material away from the surgical site and out properly aligned outflow areas on the other side of the inflow. And then again, you use these air filters that remove most of the germ-sized particles that exist. So we wanted to look at our patient care areas, the operating rooms and the offices, which are built in compliance with all the guidelines and where we have very low infection rates. And when we have very low infection rates, it makes us think that we operate in a very clean environment. What we wanted to see is if that was really true. So on the left here, you can see our operating room, and up in the top is the ceiling inflow of air, and there's the surgery. But where is the outflow? The outflow is in this corner behind this anesthesia cart, and it is almost unavailable to the air that comes down from the ceiling. And that's the only one that we have. There's no other one outflow area in the room. So one blocked area in the lower part of the room. In our office, and they just took a standard office room where we see patients and do injections and things. And you can see we have a central inflow of air and actually no dedicated outflow fence anywhere in the room. So what we have are these patient care areas not really meeting the idea of laminar airflow. And what we have ultimately is not proper inflow and outflow, but we have a turbulent mixed ventilation system, which is not necessarily clean air. So we wanted to do a study to look at how clean it was. And we got a particle counter that works on light scattering that can measure particles in the air. And it can measure particles of small sizes, which we will define as 0.3 microns to 1 micron, and large particles, which are thought to be 2.5 microns to up to 10 microns. And these particle counters are fantastic, and they can measure things with great efficiency. And if you look at particle sizes of 0.4 microns or larger, it is about 100% efficiency in counting these tiny little airborne particles. So this is what it looks like. This is me on the left in the office, and we're just showing you how we were measuring particle counts. And on the little box, you can see the sizes of the particles, the 0.3 micron particles, how many there are in just a few seconds of measurement. And of course, there are lesser numbers of very large particles, as you would expect in the air. And then you can see what we simulated also in the operating room at the head of the bed where the patient would be, where their eye would be during surgery. And we tested for 1 minute in multiple areas, in our exam rooms, in our faculty offices, in operating rooms, in a storage area, the cafeteria, the hospital parking lot, multiple areas to see what is the particle count in these sort of hospital regions. And this is what we found. If you look at our facility, which again is not, it's a normal, particularly clean, it's a clean, regular hospital operating room system. And we look at large particles. So those are 2.5 microns and larger. And they're depicted in the blue, red, and green. You can see that for large particles, the operating rooms are clearly better than the rest of these sites, in the parking lot, in the waiting room. And that makes us feel good that we don't have large particles of things floating around in our operating room. So this is kind of what we would expect. But if we look at small particles, those that are 0.3 to 1 micron in size, we can see that especially the 0.3 microns, so the smallest germ-sized particles, they are as much or more than many locations. Certainly the parking lot is bad, but our waiting room, our lunch room, the fellow's office, the storage room, they all have fewer particles circulating in the air than our operating rooms. And that we found to be kind of disturbing. So we looked around and noticed other things. We took these particle counts and found that areas that have the highest traffic, people moving in and out all the time, have higher particle counts. They were fairly high in our exam rooms. And then we looked and found that in the busiest traffic areas that we could find higher counts, whether it was the break room or the checkout area or our cafeterias or even the bathroom. You notice the bathroom itself had less particles than some of our clean patient care areas. We also found in the operating room that the particle counts are much higher after the first case than before. And that has to do likely because of the traffic in and out of the room and all the things that are open and such. So we wanted to see then, what can we do about this problem? And we looked at a company that provided a horizontal laminar airflow unit that was portable to try to improve the airflow dynamics and the sterility in both the operating room and the office. It's an inexpensive and easy thing to bring in to try to reduce these circulating bacteria, high counts of bacteria. And particularly, as we move in and out, surgeons and people in and out of the room, we wanted to create as potentially sterile an environment as we can in the operating room and the office. So this device is a horizontal unit. It's fairly small, and it is something that filters the ambient air. And you put it about 75 to 115 centimeters from the site of the patient. And it literally reduces bacterial cell counts down from what is normal in a current operating room standard of 50 to 200 colony forming units per meters cubed to less than 1 to 5. So it's a tremendous reduction in the bacterial counts with this ultra clean laminar airflow that blows across the surgical site. So we look at some of the data that's been presented using these units in some early trials with simulated cataract surgery. It reduced colony forming units by over 100 times. You can see it also in these agar plates. In the simulated intravitreal injection studies, it reduced colony forming units by 90 to 120 times. And in real neurosurgical procedures in Sweden, it was shown to reduce the colony forming units by more than 50 times. So this has got some good science behind it. So we decided we would do it in the office. So we tried testing this unit, and you can see it blowing across me in the simulated injection. And we did things first, just standard quiet. Then we would do it while increasing the activity around the area of the procedure. So talking or rubbing your hair or rubbing your hands or your arm. Each one of these things was done and simulated 3 times for 1 minute, and we counted particles. And you can see here that this particle count before turning it on are really quite high just in our standard clinic room. So this is one of my fellows at the time, and we were testing this, and you can hear it. You can see this is it before turning this unit on. And the particle counts, I don't know how well it shows up, are going up very, very fast. And after just a few seconds here, we're at 4,000 particles of the 0.3 micron size. Then we turn this unit on, and we measure the same device, and he's holding it in the same location. And you can see the particle counts are 16, 18. So from 4,000 to 18. So it's a remarkable amount of cleanliness that this provided in this situation. So we did this, and we did it in the operating room as well. And this is what our composite results showed, that even when we did things in these high patient traffic areas, we could take baseline measurements of small particles, turn the device on, and the measurements would drop to nearly 0. We would turn it off, wait half an hour or so, let it go, and the particle counts would build up again, turn it back on, and they would plunge again. And the same graph is seen for large particles also. We did this in non-patient care office spaces, and we saw the same exact curve where we get an immediate and dramatic reduction in particles right away from turning on the machine. And similarly, we would turn it off and then turn it back on. So we wanted to see what the impact of the physical maneuvers were, like talking, coughing, sneezing, etc., because we do know that the goal is to be ultra clean, and that would allow us, our goal is to have particle sizes of 2.5 microns or less, which are the bacteria, and viruses, and bad other things, proteinaceous things in the air. We want to eliminate those. So we showed the effect of talking or rubbing the skin or stroking the hair at baseline for small particles, and we see the same for large particles. And then once you start talking, particle counts go up. If you rub your hair or scalp, particles go way up. And similarly, rubbing your forearm, or if one of my fellows had a beard and was rubbing his beard, and it showed the same thing, dramatic increases in particles if you do things. But here is my fellow rubbing his hair. And again, once this machine was turned on, he could take very high particle counts, continue to stroke his hair, and all the particles went down to nearly 0, both small and large. Same thing about rubbing the forearm. He could continue to do that, but with the machine on, the particle counts went down to nearly 0. And similarly, when talking, same curve. And we saw the exact same thing in the operating room as well, with turning the machine on and having immediate resolution when the patient was talking in the operating room. So what we've shown is that we falsely believe that our current operating airflow is sterile or optimally clean, and that these current ventilation systems that we have in all of our operating rooms or our offices make us susceptible to potentially hazardous airborne particles. We need to do more testing, because there is a question of, well, how important is this if we have low infection rates? Do we need it for eye surgery because endophthalmitis is low anyway? But we know that we are functioning in not clean areas. And we know that there are risks, particularly with cataract surgery and other procedures. And we have better technology that can make these things resistant and make almost any space, whether it's an office or an operating room, cleaner. There are other issues too, because of the rise of COVID and other infectious disease. Right now, this portable unit that I showed you is being used in multiple settings, whether it's in operating rooms, office procedure rooms, and interestingly, in underserved areas where you don't have as many nice hospitals or operating type rooms to operate on people in outlying underserved regions. And it's currently used in more than 150 centers around the world, mostly in Europe and a few in the Americas. And here are just some pictures of it in use in facilities around the world, whether it's in procedure rooms like these, or in full operating rooms like these, to try to minimize infectious particles. But there's another thing. What if you could use a modular unit like this, which now exists, which basically creates an entire sterile field that functions as a full operating room, where you get sterile downward laminar airflow the same way. It's being used more and more. And with this unit, which can be brought in temporarily and fits different size rooms, patients, for example, in this case for eye surgery, can be rolled forward and the surgery performed with the surgeon and his draping on one side, with all of the operating room conditions in the local area around where you're operating, and the patient on the other side, sort of the lower half of their body, is on what would be sort of the non-sterile side of the room. And again, all the testing have shown that when you do particle counts on the operative side of this unit, that they're much better than in your own standard operating room that we operate in every day in the hospital. So these are some pictures of that unit being used in facilities around the world. And this is currently being used in about 50 centers, again, mostly in Europe, but a few in the Americas as well. So there's actually one other thing that we've been looking at is, what about the rooms that we sit? What about the room I'm in, or the room all of you are in, where there are particles that are clearly at risk, putting us at risk? And now, especially with COVID-19 and all the variants that are coming, everybody wants to be in as clean of an environment as possible. So there are units that are being developed that could potentially sit in any indoor environment and filter and recirculate the air. This is a unit made by the same company that has made those other ones, which eliminates these particles down to the level of the COVID-19 virus. So particles that are 0.1 micron in size or larger. This device has a filter that lasts 1 year. It has an internal UVC function that kills all of the filtered bacteria and viruses once they've gone through the filter. And really, it just connects to any ventilation system or even the outside air. And it really does improve things. And it can be used in a variety of settings, whether it's in your workup rooms, your exam rooms, the waiting rooms, emergency room situations, sterile preparations, even in home care situations. If you have an asthmatic or an immunocompromised patient, we can imagine it being used in the food industry and other areas. But these small devices can also exist to create cleaner, more sterile environments around us. And here's just a little bit of the data used to validate this equipment. If you look at the smallest particle sizes, the ones that are at the level of viruses like COVID and others, when this machine is started, measured at 2 meters and at 4 meters, we have large particle counts of the very small level. And when this machine has been on for 30 minutes or an hour and just left running in the corner of the room, you can see the very, very dramatic reduction in airborne particles. So there are solutions that are out there for these things. And I think we have shown that the biggest surgical myth is really busted, that we don't have clean or sterile operative air where we are, and that our ventilation systems are really to blame. but that current technology can improve air cleanliness in all of these operative environments, and that new devices can make air in any space cleaner than our current operating room, particularly even in the most forward-looking settings, like in the office for future work. I want to thank you for your attention and for inviting me to speak to you in this wonderful collection of the EGVRS.
So thank you, Dr. Tariq, for such an eye-opener presentation. You made me think, what are the inlets and outlets in the operating rooms at the hospital where I work? And I really didn't think I quite know where they are exactly, but yeah. Tomorrow I will check them. But yeah, like you said, I mean, we have in ophthalmology in general, we have quite a good records against endophthalmitis. But of course, with a larger number of patients that we're doing, we're performing surgeries like injections, which become a very high practice nowadays. And I know you had a great deal of research done on the injections and on the intravitreal injections and how to protect against endophthalmitis. I guess this mobile station can be very helpful, especially you know, it's not a practice in Cairo or in Egypt in general to inject patients at the office, but I think with a large number of patients might have to do that. So if this machine can provide us with better security, I guess that's the way to go.
Yeah, you know, I think about that when I have visited Egypt recently and other countries as well. You know, it makes me think that there probably are not enough injections being done in many countries because of access. You know, in the United States, we have so many patients, and I know that the incidence of some of the conditions that we inject may be different in the Western countries, but I know there are many diabetics, for example, in the Middle East, and who would likely benefit from more frequent injections. And I'm sure that access must be somewhat difficult if they're always done in the operating theater, because there are just too many patients that would need these very, very short procedures done. And if something like this could provide the comfort to surgeons around the world that they are doing these procedures in the cleanest environments they can, cleaner than the operating theater, yeah. That ultimately translates into better patient care, because people will be injected more frequently, more easily. You know, so I think that could have a big impact on care in the future, just from an access perspective, let alone the reduction of endophthalmitis.
Yeah, and through your research on endophthalmitis related to injections, can you give us one advice, one single thing that we have to do, whether we inject in the office or in the operating room, one single advice that can provide 100% prophylaxis in those cases?
Well, 100% is probably, I would be
99.
Extremely wealthy if I could figure that one out. But I think, you know, what our papers have found to the most significance is that, you know, you need to obviously follow sterile procedure, that using povidone iodine is really the most important thing to sterilize an area. So it has to achieve contact with the injection site, and it has to be there for, you know, at least 20 to 30 seconds. Okay. The problem, and what we found, is that some places, and maybe it's less of a problem in the operating room, but certainly non-operating room situations, some people were using the heavy lidocaine jelly or some viscous material, and then the betadine would go on top of that. So the betadine, the povidone iodine, would not reach the surface of the eye adequately. And we found a high correlation with increased endophthalmitis rates with the use of heavy anesthetic gel or drops. So that would be, if you wanted to eliminate the most obvious single reason, that with one move, that would be to not use heavy anesthetic gel or liquids. Use just, you know, aqueous-like topical proparacaine or lidocaine, something like that, and not use a heavy gel.
Okay, excellent advice. We're about to end this episode, but I have one last question for you. I know you have a great interest in martial arts, right?
I was much more so when I was younger, but yes, you remember, yes.
So my question to you, have you ever had to use this in the office? I want you to tell me one funny situation in the office, maybe with an angry patient.
You know what? You know, so that is very funny, and I joke with my staff in the office. I've never had the opportunity to use it, and I think that's obviously good. The teachings of martial arts are to not have to ever use it. You know, the idea of the martial arts is also to focus the mind, and you want to avoid situations of physical contact. So in that regard, I guess it's working, but you always want to be prepared if you need to. So I joke with my staff a lot about how I just once in my life want to try to see if everything I've learned works in real life situations.
Yeah.
And it's never happened, Mohammed. Never had to use it yet.
Well,
but I will tell you, I'm always looking for the chance. Exactly.
Well, it's been a pleasure, really, Tariq, enjoying chit-chatting with you and enjoying your presentation.
Sure.
And I really would like to invite you to one of our meetings in Cairo to meet you in person soon. Hopefully.
You know, inshallah, I will be there as soon as I possibly can. I don't, I know that now the borders are opening up, and you know, I hope that the in-person meeting invitations will be there. And you know, Cairo is, and Alexandria both, I have family from there as well, are really my home. And I was raised in a very traditional Egyptian home, and that is in me, and it's still, I consider it to be my motherland. And I hope to be there as soon as I possibly can, as soon as I'm able.
Inshallah. Thank you very much. And
all right.
enjoy Ramadan, and see you soon. Thank you very much.
Thank you.